So I love this quote. It comes from a very famous British physician. Medicine used to be simple, ineffective, and relatively safe. It is now complex, effective, and potentially dangerous. And whenever I tell our residents, or I show them this slide, they're so happy because the residents always tell me they work much harder than I used to work. And I told them they actually do work harder, although they work less hours than I used to work. I already mentioned in my previous session I'm a fan of RCTs, and the reason I'm a fan of RCTs is that our RCTs really do present causality. And so if you're really interested in changing clinical practice, causality is critical. That's also true of meta-analyses, but as I said, in general, I think RCTs are the lifeblood of clinical medicine. I would say as a discipline, unfortunately, child health has an enormously limited number of important randomized clinical trials that are published each year. I look at all of the major journals, the major pediatric journals, there's 5 or 8 of them. I look at all of the major journals, Lancet, JAMA, NEJM, BMJ, and then I also get an abstracting mechanism that I used to write for called Journal Watch, which is a wonderful abstracting mechanism. It comes out electronically every day, it's published every month. There's Journal Watch, Pediatrics and Adolescent Medicine. They have about 300 or 400, they go through about 200 journals each month. And so it's a really good way of keeping up with literature. So this is a paper that was published late last year. And the question is whether or not children with simple febrile seizures need LPs, because I think that was decided many years ago that children who have a simple febrile seizure do not need a lumbar puncture unless they have signs of meningitis. I've always said to families, if their child has a simple febrile seizure, the last thing they want to do is rush to an emergency department. In the United States, if they rush to the emergency department, they were likely to have an LP. So I tell them, wait an hour or two until your child's doing better, then take them to the emergency department. But it's a different question about whether or not children with complex febrile seizures need lumbar punctures. Are they at greater risk for having bacterial meningitis? So children with simple febrile seizures, non-focal, more than 24 hours, do not require LPs. But what about children with complex febrile seizures? And this is a review of over 500 children between 6 months and 6 years of age with their first complex febrile seizure identified between 1995 and 2008. The time period, particularly in the United States, is critical because it follows the introduction of pneumococcal and H-flu vaccines. And the rates of meningitis in the United States following the introduction of those two antibiotics, those two vaccines, is plummeted. So in the United States, H-flu used to cause 15,000 cases of bacterial meningitis. Last year it caused 500. So one of the reasons pediatricians sleep much better at night in the United States is because of the H-flu vaccine. So 340 of the 526 infants and young children in this study had lumbar puncture. Only 14 had CSF pleocytosis. 3 had bacterial meningitis, all with staph pneumonia. 2 were vaccinated, had their complex febrile seizure prior to the introduction of the conjugate vaccine, and 1 was non-responsive at presentation. And I've always made the case that I don't think it's very difficult, or one should not tell physicians that they need to do an LP on a non-responsive child. I think most of us would know that. None of the 161 patients who returned for follow-up had bacterial meningitis. And this was the conclusion. LP should be performed on the basis of clinical suspicion and additional signs and symptoms that are suggestive of meningitis. And you can see my comment, I don't think that's very helpful. But going on, the prevalence of bacterial meningitis is quite low. I suggest that physicians can forego a lumbar puncture in a child with a complex febrile seizure after a period of observation in well-appearing children without overt signs of meningitis. So I think over the last 10 years we've learned that children with simple febrile seizures don't only need LPs, and I think that the same is now true for children with complex febrile seizures. So in the United States we continue to use IV hydration rather than oral rehydration solutions, so we are much further behind the rest of the world. The reason we tend to use IV hydration in United States is because we find it easier to administer, and it's much more expensive. And so in the United States, the goal is often to make healthcare as expensive as possible. So we've tended to avoid oral rehydration solution. But this was like a taste test study, and I really liked it. So this was oral rehydration. It was published in Fred Rivera's journal. Fred is a colleague and friend. 2010, 3-treatment, 3-period, randomized, blinded, crossover study, only 66 children, all 5 to 10 years of age, presented to an ED without GI complaints, and they were asked to taste 3 oral rehydration solutions and drink as much as they could in 15 minutes. And the 3 solutions that were available were Paediatric electrolyte, which contains both sucralose and is fruit flavored, and Enthalite, which contains rice syrup solids. And in the United States, there's a famous rating of restaurants called Zagat's, and this is the Zagat ratings of oral rehydration solutions, and they really appear very different. Pedialyte, the infants, the 66 infants, when they were drinking Pedialyte, took 22 mLs, Paediatric electrolyte 17 mLs, and Enthalite 17 mLs. And when either they or their parents were asked what did they think tasted best, you could see that Pedialyte was more successful on the visual analog scale, where 0 it didn't taste very well, and 100 where it tasted really well. And best tasting, as you could see, Pedialyte. And what's really interesting, in the United States, not only does Pedialyte taste the best, it's also the least expensive. So if you're really interested in getting oral rehydration solution in your clinic, I'd go with Pedialyte. Now, there was a debate yesterday about urinary tract infections. I love urinary tract infections because it's possible that we've been wrong for the last 20 years. Now, it wouldn't be the first time we've been wrong in pediatric medicine or in medicine in general. We have a very important article coming out January 4th by John Ioannidis, who's kind of a methodologic whiz. And his viewpoint is, why is it that we take so long to retire therapies that have seen the better part of valor? The one that's currently being debated is what's the appropriate hydration solution when children are admitted to the hospital. And I think for many of us, for many years we've used quarter or half normal saline. I think the most recent data have suggested that quarter and half normal saline are inappropriate for virtually all age children when they're admitted to the hospital. But that's me meandering, I apologize. UTIs. So this is the last of 6 or 7 studies that have now been published on UTIs in the last couple of years. This is from Australia. 576 children with UTIs, median age 14 months, 64% girls, 42% had reflux. And they're assigned to prophylaxis or no prophylaxis for 12 months. UTIs developed in 13% of the treated group and 19% in the placebo group. So that's a number needed to treat of 14. It's very, very important when investigators report randomized clinical trials to tell you what the number needed to treat is. That's not an unusual number needed to treat. Anywhere around 10 to 15 is very common, so you actually have to treat 14 people for one to benefit. Really successful interventions are 5. Less effective interventions could be 50. Now, if you're preventing death, you may be willing to have a number needed to treat at 50. Age, sex, and reflux status did not impact the results. However, the most critical feature is not whether or not you prevent urinary tract infections. The really important issue is what happens to the actual kidney during that time period. Abnormal kidneys at baseline, 49% versus 46%. In terms of the renal scan, intervention group 13% improved, control group 14% improved, unchanged 25% and 23%, worse 7% and 8%. This is probably the 4th or 5th randomized clinical trial to talk about antibiotic prophylaxis in the face of reflux. And I think more than ever, the role of imaging has become increasingly less certain. Now, what's striking to me is the great divide of the Atlantic Ocean. So in the United States, we rarely do DMSA scans. We much prefer ultrasounds and VCUGs, whereas in Europe, you've tended to do much more DMSA scans. However, it's very uncertain now whether or not they're indicated, with one caveat. So it's very clear now that a normal prenatal ultrasound obviates the need for post-UTI ultrasounds. There's an article in New England Journal of Medicine and Archives of Disease in Childhood, both published 3 or 4 years ago, that if you have a normal prenatal ultrasound, then if a child is diagnosed with a UTI in the first 6 months of life, the repeat ultrasound does not add anything to the prenatal ultrasound. The NICE guidelines released in 2007, which were hugely controversial, suggested that imaging to detect reflux is unnecessary. And they go on to say ultrasound is only indicated in children who fail to respond to treatment. Those who have non-E. coli infections are often much more likely to have reflux, and those with complicated disease, which they define as non-responsive in 24 hours. After looking at those studies and a couple other RCTs that I did not mention, the American Academy of Pediatrics just last month released its new guideline, which says, after the evaluation of the first febrile UTI, it should include a renal ultrasound, but there's increasing evidence that antibiotic prophylaxis for low-grade reflux does not improve outcomes. So they no longer recommend a routine VCUG. In Europe, that would be no longer recommending a routine DMSA scan. So we could debate prophylaxis, but I think the real discussion points for clinicians really starts with, does the child have reflux or not? Because I think most people recognize that the 6 or 7 studies that I've alluded to have had very, very few children with grades 4 and 5 reflux in them. I think the data has accumulated that for children with grades 1 and 2 reflux, they do not any longer need antibiotic prophylaxis. 3 is uncertain, 4 is uncertain, 5 is uncertain. The problem for me, when NICE says really don't do any studies, is if I'm looking at a child and he or she has a UTI, I don't know if they have reflux. And so the question is whether or not an ultrasound is sensitive and specific enough in detecting reflux. Part of it depends on who you ask. Our ultrasonographers, when I was at Boston Medical Center, would say if it was grades 3, 4, 5 reflux, they were comfortable that the ultrasound was sufficient. And since that was the grade of reflux that I was interested in, we felt comfortable stopping after an ultrasound. I would say though, if you don't have as much faith in your ultrasonographer and you're a believer that we don't have enough data about grades 3, 4, and 5, then you may need to do another test to decide whether or not you want to continue with antibiotic prophylaxis. Part of the struggle is that there's not a lot of good data about antibiotic prophylaxis, but on the other hand, the number of children with high grades reflux have been very limited in those studies. But I think this is a really important change in management over the last 10 years. We've become so aggressive at detecting UTIs. What we've done after that probably has not been appropriate. This was published last month in Lancet. This is about the 5th study to look at pulse oximetry to screen for critical heart disease. This is an enormously complicated area. Are there any pediatric cardiologists here? Okay. Are there any neonatologists here? All right, good. If I say anything really bad, they'll tell me. Okay. The reason this is so complicated is that there's 3 issues that emerge in each one of these randomized clinical trials. The first is at what time period do you do the pulse oximetry? And the results of all of these studies where you're looking to eliminate critical heart disease, but you don't want to create so many false positives that you then force a lot of cardiology follow-up. It really depends upon whether you do the pulse oximetry at 6 hours, 12 hours, 18 hours, or 24 hours. So that's the first very important variable. The second is, what value do we use for cutoff? 92, 94, 90. It all generates different receiver operator curves. So there's a lot of complicated issues. And the last is, what do you consider critical heart disease? So there's three very important variables that sort of weave them through these articles, and they all do it a little differently. They all have slightly different definitions of what's critical heart disease. Some of them said, well, we detected all of the critical heart disease, but other people have looked at those papers and said yes, but 90% would have been detected without using pulse oximetry. So I think the real question is, what does pulse oximetry add to clinical examination? So for example, I don't need pulse oximetry to tell me a child who's blue in the first 6 hours needs to see a cardiologist, okay? That's not the patient that I'm having trouble with. So this was the largest assessment, I believe, the second largest assessment done to date. More than 20,000 asymptomatic newborns across England, gestational ages, all more than 24 weeks, and they were delivered at 6 maternity hospitals. 195 infants with oximetry saturation less than 95%, so that was the magical number in this study, in either limb, or a difference of greater than 2% between upper and lower extremities. So that was what they were determining was an abnormal pulse oximetry. 192 underwent echocardiography. By age 1 year, 24 were diagnosed with critical heart disease. Underwent intervention by 28 days. 29 had severe lesions. So they really tried to differentiate between critical heart disease and the 29 who had severe lesions. They had a sensitivity of 49%. And the pulse oximetry screening identified 18 of 24 infants with critical heart lesions and 8 of 29 with serious lesions. Sorry for the typographical errors, 169 infants with abnormal pulse oximetry results were, well, the conclusions, there were many false positives, there were some false negatives, and I think, unfortunately, even though this is the most recent paper to talk about pulse oximetry, it remains an unsettled issue. But I do think if you're taking care of newborns, it's worthy of a discussion in your neonatal intensive care units and your well baby nurseries about whether or not you're going to begin to employ pulse oximetry. It's very, very similar to the discussion about whether or not all infants in resource-rich countries should have transcutaneous bilirubin levels before they leave the hospital. Question?
Just a comment. Sensitivity 49% is 1% worse than critical control.
Yes. No, I mean, so for me, it depends on what the cost, how many are you going to miss, and what's the cost of identifying children who don't need it. I think if it's driven by pediatric cardiologists who end up seeing children who they think should have been identified, they're really in favor of pulse oximetry. I think epidemiologists who look at the same data but in a different way are much more concerned about the false positives, for example. And this, I know, was discussed at length in the debate about lipid screening, where the same thing is going to be discussed and debated. So is it worth over-identifying children for the few you'll find? And for me, there's a lot more complications in the discussion that particularly in lipid screening, even more than pulse oximetry, that need to be discussed. It becomes very nuanced. STIs in adolescents. This is an enormously important paper because of the current recommendations about HPV vaccine. Now, I give my pediatric colleagues in the United States a shout out. We are unbelievably good about vaccinations in the United States. Our vaccination rates exceed 90% for virtually every vaccine except this one. And that's because in the discussion about HPV vaccine, it's been about using a sex vaccine in pre-adolescent girls. But I want to show you data as to why that recommendation is so critically important. In the United States, something that will help the discussion is that the committee in the United States that makes recommendations for vaccination just recommended vaccination of males. And there had been concerns in the United States that this was one of the few vaccines that was ever gender specific, and it was creating a lot of conflicts for people. Prevalence of chlamydia, trick, HSV, GC, HPV among 808 adolescents who participated in the national survey in the United States. The prevalence of 5 sexually transmitted infections was 24%. 18.4% to 30.9%. And it varied with age and the report of being sexually experienced. And here are the data, and the two rows that I really want you to look at are the first and the second. The first is HPV, the second is chlamydia. So for HPV, at this age group, 808 adolescents, and then the ages are broken down on this slide. 18% already had HPV infection. 29.5% of those that were sexually active, 404, already had HPV infection. 4.6% who reported never having sex, and 9.4% of the 14 to 15-year-olds. That's why in the United States, the recommendation for HPV vaccination to complete the series is prior to the age of 14. It's because of these data. These data existed before, but this is a follow-up study of the previous data. That by the ages of 14 or 15 in the United States, a substantial percent of young girls are already HPV positive. And it remains uncertain about the effectiveness of HPV to prevent the development of cancer if girls have already developed HPV disease. And so this, I think, really renews or justifies a recommendation about the age of HPV vaccination in the United States. I told you the other row that was of great interest was chlamydia, 3.9% for all, 7.1% who were sexually experienced. Currently in the United States, the Centers for Disease Control recommends that every adolescent girl once a year be screened for chlamydia. Our screening rates for chlamydia in the United States are about 15%. So it's one of the few areas in which the United States has not done very well. Part of the reason is that the average adolescent in the United States sees a primary care provider less than once per year. So part of it is that adolescents don't see very frequently. So I think that's what is reflected in the chlamydia data. Now what's striking to me, the most recent data that I saw from the UK, is because they have a different strategy around HPV vaccination. They have a much more public health policy, school-based vaccination to catch up, that their vaccination rates in the UK are running about 80 or 90%. In the US, they're hovering around 50%. So this study is a little older, but it was so strikingly important to me that I show it every time I give this talk. And it's particularly relevant to me because in my division at BMC, for the last 5 years, we had 1 or 2 adopted children every year. And it was like part of our BMC family, like we had 14 faculty and lots of research assistants, but if you came to our Christmas or our holiday dinner, it looked like the United Nations, everyone really loved it. But this paper actually made my faculty behave differently. So should internationally adopted children be retested for tuberculosis? There's 527 internationally adopted children in this study. The mean age was 23 months. Most were from Russia, China, or Guatemala, and they were all tested within 1 week of arriving in the United States. 79% were negative, and 21% were positive. They all had reactive time tests, TB tests of greater than 10 millimeters. None had active disease, so they would have all been put on INH. So that's the 21% that were diagnosed with latent tuberculosis. But look what happened to the children who were negative when they went and retested them. Only 49% were retested within 3 months, so they couldn't get the other 200. Of the 203 that were retested, 191 were all read within the appropriate time period, 48 to 72 hours. 20%, 38 of the 203 were now positive. So these were children who were TB negative at the time of entry into the United States, and then 3 months later were TB positive. That totally changes their management. Totally changes their management. So at initial testing, BCG scar and better nutritional status were significantly related to a positive result. At retesting, children who were positive were significantly more likely to improve their nutritional status. So it's likely that they had a non-reactive assume all the children who were not retested were negative, because I already told you that only 203 out of 500 were retested, and the 12 children who did not have their TST read within 48 to 72 hours, if you assume they were all negative, the positivity rate would still be 38 out of 416, or 10%, 9%. So I would argue internationally adopted children in any of your countries should be tested for tuberculosis if they come from a highly endemic area, and they should be retested for tuberculosis within 3 to 6 months. I'll stop with this because it's already 4 o'clock, although I have about 5 more papers. So in the United States, the pendulum is swinging back and forth around the treatment of acute otitis media. Some people feel like in older children it's a benign disease, or at least you could wait and watch. People have been a little less certain in young children. So this is 2 double-blind randomized clinical trials. Acute otitis media was defined by the acute onset and presence of middle ear effusion, bulging tympanic membrane, and ear pain, or if the TM was red. Both studies are in NEJM from 2010. This is the first of the 2 studies. This is the finished study. 319 children, 6 months to 35 months, with acute otitis media. And so these are younger children. So the discussion really isn't for children less than 6 months. I think most people would argue children with less than 6 months with acute otitis media should be treated with antibiotics, although at least most times when I followed up with resident, they actually weren't looking at the tympanic membrane, but that's a slightly different story. I would argue diagnosing AOM in children under 6 months, or certainly under 3 months, is very, very difficult to do. But children under 6 months, I think there's general unanimity about being treated, and then older than 2, I think the wait and watch. So this is 6 months to 35 months. Treatment failure, no overall improvement by day 3. This is their primary outcome in the finished study. Worsening condition, no improvement in signs or symptoms, was less common in the antibiotic group, 19% versus 45%. This was a number needed to treat of 4, 3.8. So you have to treat 3.8 children for 1 to benefit. However, children who received antibiotics, not unusual at all, were twice as likely to develop diarrhea. So that's the finished study. This is the Pittsburgh study. 291 children, similar age range, a little younger, 6 months to 23 months with AOM, received the moxicopulame or placebo for 10 days. Symptom resolution, antibiotic versus placebo. Day 2, 35% versus 28%. Day 4, 61 versus 54%. Day 7, 74 to 54%. Children who received antibiotics were more likely to develop diarrhea, 24% versus 1%. And diaper dermatitis, 24 versus 4%. Here the numbers are much closer. It's a little hard to decide whether or not those are really successful. They are significantly different, but again, you would need to decide clinically whether or not you think those are important differences. And so I asked 2 colleagues who I know would have very different opinions about these data. And that's why I love medicine so much. So they're looking at the same data, and they interpret it very differently. So the first is Jerome Klein, who's considered one of the world's experts in otitis media. A friend, a colleague, and leading expert. More young children with a certain diagnosis of acute otitis media recover more quickly when they are treated with an appropriate antimicrobial agent. Peggy Weintraub, a friend, a colleague, another ID person who writes with me at Journal Watch. When do we need to treat, and when can we watch and wait? Placebo was a successful option for more than half the children in both studies. For children who look well, are old enough to be comforted with supportive care, watchful waiting remains an option. So again, Dr. Klein would treat, Dr. Weintraub would consider even in young children waiting and watching. I will do one more study. I apologize because I do think this study is really, really important. So last year, in a kind of carefully worded but obscure American Academy of Paediatrics guideline, they recommended for all children at high risk for the development of atopic disease be given extensively hydrolyzed formula when they stop breastfeeding. That is an extraordinary recommendation. And whenever I've given this talk in the past, people don't even know that the Academy's made that recommendation. So breastfeeding, breastfeeding, breastfeeding. But when you come off breastfeeding, if you're at very high risk for atopic disease, the Academy of Paediatrics recommends extensively hydrolyzed formula. Just 2 comments for people who are familiar with extensively hydrolyzed formula. A number of people always say to me, it tastes not very good in comparison to the regular formulas. Although that's a true statement, to the infant who's never had formula, it tastes great. Okay, so it doesn't taste very good for you or I, but if you have a really hungry infant who's never seen a regular formula, the partially or extensively hydrolyzed formulas are perfectly fine. The second is, the cost is fourfold more than the regular formulas in the United States. The recommendation is based principally on this study. This was a meta-analysis of 18 studies. Over 1,000 infants received partially hydrolyzed formulas or extensively hydrolyzed formulas. Infants were considered at high risk for allergen if the family history was positive for atopic or allergic disease. Infants who received partially hydrolyzed formulas had a 45% lower risk for the development of atopic dermatitis. That's a number needed to treat of about 3. The risk at 6, 12, and 36 months was 59, 41, and 24% lower. There were 4 high-quality studies buried in the collection of the studies. The results were similar. And later that year in 2010 in JAMA, we had an evidence review of the same issue. And the only recommendation that this evidence review was willing to make around infant nutrition, other than that infant should be breastfed for 6 months, was that the review supports that extensively hydrolyzed and partially hydrolyzed formulas may reduce infant and childhood cow's milk allergy in high-risk infants. But formulas at high risk remain poorly defined. And so it appears that partially and extensively hydrolyzed formula prevent development of eczema, and there's some evidence for the protection against food allergy and asthma, although they're somewhat less certain. So this would be really a fundamental change in the way we feed young children. Now what's really interesting is I didn't give you the rest of the reports that the US has released, which when I was a young person in medicine, we always used to say to families, breast for as long as you can, certainly to 6 months, then formula to a year, and then when you begin to introduce foods, you should introduce the highly allergenic foods very late in life, after age a year or 18 months or age 2. So no eggs, no fish, no peanuts into age 2 or 3. And I think probably most of you are aware that that recommendation was probably wrong, okay? That what we probably did by making that recommendation was to end up allergenizing many more children. And the study that's received the most attention is a study from a few years ago that compared Israeli children in England to Israeli children in Israel to control for genetics. In Israel, Israeli children see peanuts beginning in a paste-like form at age 3 to 6 months. In the UK, they were holding off to age 2 or 3, and the risk of peanut allergy in Israel was 100-fold greater than it was in Israel. And so people have really begun to question whether we know what we're doing around early infant nutrition beyond saying that one should be exclusively breastfed for 4 to 6 months. I will stop there. I will stay behind. Thank you very much.